and welcome to the fifth talk in Parkinson's Disease Foundation's sixth PD expert briefings, maximizing PD medications, how to get the most out of your treatment plan. We're pleased to announce that today's talk, as well as the other expert briefings of this year's series, have been created in collaboration with our partners, the Houston Area Parkinson Society, the Michigan Parkinson's Foundation, and Parkinson's Association of the Rockies, and the Parkinson's Association of the Carolinas. And of course, I also want to thank our sponsors for this series. Without their support, this would not be possible. AbbVie Incorporated and Acadia Pharmaceuticals. Electronic copies of the slides for today's talk can be downloaded from the reminder email you received this morning or from the PDF webpage that highlights this talk. If you're a qualifying health professional friend, you can earn one free CEU through the American Society of Aging. If you registered as a health professional and indicated you would like a CEU, you'll receive an email by the end of the day with steps on how to collect the CEU. You have just 30 days, that is until May 28th, to collect your free CEU. Now it's my distinct pleasure to welcome our speaker, Dr. Connie Marras. Dr. Marras epitomizes the role of a physician scientist. She's a neurologist with advanced training in movement disorders and holds a PhD in epidemiology. She publishes widely on the clinical aspects of Parkinson's disease. She's currently an associate professor of neurology at the University of Toronto, and she practices medicine at the Morton and Gloria Shulman Movement Disorder Center and the Edmond J. Safra Program in Parkinson's disease, located at Toronto Western Hospital in Canada. Now I'd like to turn the floor over to our speaker, Dr. Connie Marras. Connie?
Thanks very much, Jim. It's my pleasure to talk to you today about the medications that we use in Parkinson's disease and how to maximize their benefits and minimize their adverse effects. So as part of today's presentation, what we'll be doing is reviewing first the classes of medication for Parkinson's disease, with particular focus on the motor symptoms of Parkinson's disease, learning about the good and bad effects that can be expected from them, and understanding ways to maximize their effectiveness and minimize their side effects. So first of all, I'd like to just review what is familiar probably to many of you, but so that all of us are familiar with the terminology. The main classes of medications for motor symptoms in Parkinson's disease. First of all, levodopa is probably the most commonly used medication for Parkinson's disease and comes in several different forms, usually levodopa carbidopa, also called Sinemet or levocarb, and levodopa benserazide, also called Prolopa, and more recently an intestinal gel formulation infused directly into the small intestine called Duodopa, or in the United States branded as Duopa. There are the dopamine agonists, which you may know as pramipexole, ropinirole, a patch called rotigotine, gabergoline, apomorphine, or others. And we also have the monoamine oxidase B inhibitors, which are called either selegiline or rasagiline, catechol O-methyltransferase, or COMT inhibitors, and entacapone or tolcapone. And then the last class that I'll mention are the anticholinergic medications, of which the most commonly used, at least in North America, would be trihexyphenidyl, or known, at least here in Canada, as Artane, under the brand name of Artane. So we also have many classes of medications for non-motor symptoms in Parkinson's disease, and I'm happy to take questions about these in the question period, but they'll be beyond the scope of the talk, the 40-minute talk that I have for you today. So in order to understand the rationale for the best ways to take medications for Parkinson's disease, it's useful to know a little bit about how they work. First of all, levodopa is converted in the body and the brain to dopamine. So it's a way to provide the natural neurotransmitter dopamine back to the body and the brain. And it can be used in combination with the COMT inhibitors, entacapone and tolcapone, and there are combination medications that provide these medications together with levodopa. the way they work is by increasing the COMT inhibitors, at least, work by increasing the availability of levodopa to the brain. And in order to understand why this is the case, it's important to know that dopamine can't be provided directly outside of the brain because it does not cross from the blood into the brain. And so we have to provide dopamine in the form of the prodrug levodopa. And COMT inhibitors work by blocking the conversion of levodopa to dopamine outside the brain. And thus, it provides more levodopa available to cross from the blood into the brain and then be converted within the brain to dopamine. So a corollary of this is that levodopa and COMT inhibitors can work together to increase the action of levodopa, and COMT inhibitors are always given in conjunction with doses of levodopa. The reverse is not true. Levodopa does not have to be given with a COMT inhibitor, but COMT inhibitors do not have any therapeutic action in and of themselves. The dopamine agonists mimic dopamine at dopamine receptors. They are active at dopamine receptors, but they are not dopamine themselves, and so they have a slightly different spectrum of action as well as a different side effect profile. The MAOB inhibitors, rasagiline and selegiline, reduce the breakdown of dopamine, and so, again, like the other medications that can be used to help levodopa along, they increase the availability of dopamine. And then the anticholinergics act really quite differently on a different neurotransmitter called acetylcholine by reducing its activity. And this completely different mechanism of action accounts for their different effectiveness in Parkinson's disease, which is particularly upon the tremor and less so upon the slowness and rigidity that is seen in Parkinson's disease. So I'm going to now spend a little bit of time talking about how we use these different medications. And first of all, levodopa is really the cornerstone of treatment in Parkinson's disease. It's the most common initial medication and is almost always the initial medication in older patients and often the initial medication in younger patients as well. It's the most effective medicine we have for Parkinson's disease and often has the least side effects. Other medications are largely used as adjuncts to levodopa. The dopamine agonists and the MAOB inhibitors do have some advantages in that they are longer acting than levodopa. And so as Parkinson's disease advances and the duration of action of levodopa becomes shorter, I'll talk about that phenomenon later in the talk, then adding on dopamine agonists and MAOB inhibitors can be useful in order to smooth out wearing off. In younger patients, they can also be used alone as initial treatment. COMT inhibitors are often used, as I said, in conjunction with levodopa, increase its duration of action, and are usually used to reduce the wearing off of levodopa that occurs before the next dose. Anticholinergics, I mentioned, are used preferentially to treat tremor in Parkinson's disease and can be a particularly useful adjunct for that symptom if levodopa or dopamine agonists are insufficiently effective for that symptom. I didn't mention earlier amantadine, which is used primarily to reduce dyskinesias, or involuntary movements that occur as a side effect of Parkinson's disease medications. And that can be a very useful effect. It has some mild benefits on the motor symptoms of the disease, but is less commonly used for that purpose. Okay, so turning now to what benefits to expect from medications in Parkinson's disease. The medications for the motor symptoms would be expected to improve speed of movement, improve dexterity, such as handling chains or undoing buttons, reduce stiffness of the limbs and the whole body, and can often be effective, very effective, to reduce tremor in most, but not all patients. And there are some patients where tremor is not affected by the dopaminergic medications, and in those patients, anticholinergics can be quite helpful. It's also possible that dopaminergic medications, and indeed all the medicines for the symptoms of Parkinson's disease, may help to provide more clarity of thinking, faster thinking, improve multitasking. And this is true particularly early on in the disease. Later on in the disease, the cognitive effects of the medication can be negative ones. It may improve pain, and it may improve balance, again, especially early on in the disease. And on the other hand, there are a number of problems that can be encountered with medications, including nausea and sleepiness, hallucinations and confusion, particularly in older patients with more fragile cognitive abilities. And with respect to hallucinations and confusion, the medications such as anticholinergics, amantadine, MAOB inhibitors, and dopamine agonists would be much more likely to cause these problems than levodopa, and often need to be removed if these symptoms occur. And levodopa would be least likely to cause this kind of problem. Lightheadedness related to lowering blood pressure can be a side effect of levodopa, dopamine agonists, or amantadine. And constipation is often a problem with levodopa and anticholinergics. Finally, dyskinesias, or the involuntary movements that I mentioned earlier, are a side effect of levodopa and dopamine agonists and increase in likelihood as the disease progresses. So speaking of dyskinesias, which will be a focus of some of the comments that I will make about maximizing effectiveness and minimizing side effects of medications, will be the subject of this video, which I will show you, which shows a man going through his dose cycle of levodopa. The first phase of the video will show him before he takes his medication, where he will be stiff and slow, and then the next part of the video will show him after he has taken his medication and experiencing some dyskinesias, which many of you will recognize, but if you haven't seen them before, will be a helpful example of how they can be, how you can recognize them and know what I'm speaking about. So this is him before he has taken his medication, and he is showing the typical slowness of movement that you see, more on his right-hand side, obviously, than his left-hand side.
And now the other side.
He's being asked to do this as quickly as he can, so he's somewhat more slow.
Okay, and with your right hand,
you can also see the reduction in facial
like
expression that's common in Parkinson's disease.
As big and as quick as you can. And now pretend you're screwing a light bulb like that, all the way around, as quick as you can. Now the left. Each finger in turn. Now all the way around. Okay, that's fine. Pop your hands down. Just pop your feet in front of you. As big and as quick as you can. And now lift the whole leg up like that. Now the left. Like that.
For those of you without access to the slides, we're still watching him with without his medications, and this video will play for another couple of minutes before we get back to the slides.
Just try and stand up for me. Can I see you walk? Just walk out into the corridor. And if you could walk along there, please.
Typical reduction in arm swing. of someone off medication
Up to there and
with
back again,
Parkinson's
please.
disease. Okay, and now he's taken his medication.
Back again.
And he is displaying the dancing, wiggling, twisting
And the valley
movements
is
that are
here, the peak is
characteristic
here,
of
and you get a little bit
dyskinesia
better, but you still
with
quite
Parkinson's
bad
disease.
dyskinesia, and then it gets a little bit worse
They,
again,
as
then
is
you go
typical,
down.
they affect the
So
side
even
that is
throughout
most
that
affected by
hour
his
of
Parkinson's
response,
symptoms,
the dyskinesia
and they represent
is
a state of
disabled.
excessive movement that is a side effect of his levodopa.
Can you stand and walk
Dopamine
for me?
agonists can also cause these effects,
And it
but
interferes
slightly
with the
less
walking,
so.
eh?
And any medication that is designed to increase the effectiveness of levodopa can increase
Oh, so that
the
it doesn't cause you to
dyskinesias
trip or
as
fall?
well.
No. Do you bang into things?
True.
I'm going to move on now to the next slide. And I will talk a little bit more about how to deal with dyskinesias as well later in the talk. So to maximize benefits from Parkinson's medication, we can think of various different strategies involving adjusting the dose, adjusting the timing of the medication, adjusting how it's taken with food, etc. And we'll go through each of these in turn. First of all, with respect to dose, there's a very wide range of doses needed for Parkinson's disease control that varies according to the stage of Parkinson's disease and also to the individual. And this is particularly so with levodopa. In general, over the years of evolution of Parkinson's disease, the dose of levodopa increases gradually until there is sufficient benefit to deal with the functional problems that a patient experiences and to give them a good quality of life. And in general, we start medication for Parkinson's disease when it starts to impair function or quality of life, and avoid delaying it in the presence of that kind of disability, and also avoid treating minor symptoms that don't impair functional disability. Ultimately, as Parkinson's disease progresses, somebody's tolerance of medication often is reduced, and we must reduce the dose when adverse effects appear. And over the years, there is a gradual increase, then often a decrease in dose, particularly with levodopa, and often other medications need to be stopped later in the disease. But it's important not to stop medication suddenly in Parkinson's disease, especially levodopa, as this can be quite dangerous. With respect to timing of medication, this is relevant for mainly levodopa, but also to some extent dopamine agonists. Early on in Parkinson's disease, it rarely matters exactly what time one takes one's medications, but later on it can be very, very important. As one goes through the dose cycle of medication with Parkinson's disease, and here I'm mainly talking about levodopa, after the dose is taken and the concentrations rise in the blood, dyskinesias may be experienced as the concentration gets at its peak, and then there may be wearing off of the medication with reemergence of tremor and or slowness as the concentrations fall. And this kind of dose cycle can be mitigated by changing the timing of the dose. It can be very, very helpful to a physician if patients can relate to the doctor what the relationship is between the timing of their medications and the occurrence of these different states. For example, the Parkinsonian state of slowness and tremor, very in contrast to the state of good motor function, in contrast to the state of having dyskinesias. And a diary such as this one, which we ask our patients to fill in when there's uncertainties about this relationship, can be very helpful. This is a piece of paper which I've cut off at the top so that you can't see the bottom, but if you saw the whole page, it has the whole 24-hour cycle written out so that you can indicate at any particular time of day which state that you are in, as well as when you take your tablets. And that can be a very useful thing to do several days in advance of an appointment in order to try to explain to the physician what your day is like, and allow the physician then to make proper timing adjustments to medication. So, especially as the disease advances, we sometimes run into end of dose wearing off. This is where the Parkinson's medications don't last quite to the next dose, in which case we can reduce the interval between doses. We can use long-acting formulations of levodopa, such as levocarb CR or Cinemet CR. We can add longer-acting medications like dopamine agonists or MAOB inhibitors like selegiline. We can also add a COMT inhibitor, entacapone or tolcapone, in order to augment the action of the levodopa. And if none of these strategies are possible or effective, we can sometimes recommend something we call liquid Cinemet. So this is dissolving levodopa in liquid, and then you keep the liquid as a supply throughout the day, and then take small amounts of it much more frequently. It's just a more convenient form in which to take small frequent doses of levodopa as opposed to larger doses in tablet form. And again, if this isn't effective, we can resort to advanced therapies like levodopa carbidopa intestinal gel or duodopa, and some often deep brain stimulation as well. So what about food and Parkinson's medications? This is often very confusing. Protein will compete with levodopa for transport from the gut into the blood and also from the blood into the brain. And protein intake, therefore, can often result in sudden off periods or delayed effect of Parkinson's medication. We often, early in the disease, don't advise a patient to adjust their food intake in relationship to their medications because it often doesn't make a difference. But later in the condition, it can certainly make a big difference, and avoiding protein intake 30 minutes before or at least 1 hour after medication may improve the effect. And sometimes it's necessary even to avoid protein for longer intervals around the intake of medication. Medication on an empty stomach may be even better than just avoiding protein, and I have some patients where any food intake will cause them to shut off, so to speak. Constipation is a symptom of Parkinson's disease, as many of you may know, but it can also be made worse by PD medication. And it definitely can reduce the absorption of medication and sometimes prevent its effects entirely. And so it's very important not to ignore, and drinking plenty of water and getting exercise are good general strategies to avoid constipation. And it's often better to take a daily laxative for prevention of constipation if you tend towards constipation, rather than waiting for constipation to appear and treating it as needed, which often results in a more roller coaster ride of effectiveness of PD medication. Delayed emptying of the stomach is also a symptom of Parkinson's disease because not only does the colon and lower bowel slow down, but also the upper gastrointestinal tract. And because the levodopa is absorbed just beyond the stomach, if you don't empty your stomach then very quickly, then your onset of action of levodopa will be delayed. It also causes the unpleasant effects of bloating and also gastroesophageal reflux. And we are lucky here in Canada to have the availability of a medication called domperidone to treat these symptoms. It's not available in the U.S. I believe it is in Europe, but it can be very useful to help with promoting stomach emptying. And it's also important not to ignore problems with depression and anxiety. Once again, these are common symptoms of Parkinson's disease, and they commonly even precede the motor symptoms of Parkinson's disease and can be present many years in advance. But importantly here, mood has a profound effect on the efficacy of medication and also on the symptoms of Parkinson's disease itself. And many of you are probably familiar with the experience where you can be feeling fairly well and then suddenly get anxious and your tremor comes back and you suddenly feel slow and stiff. and it's nothing to do with the timing of your medication. It's the presence of the anxiety itself that is often more powerful than any medication for Parkinson's disease. So, important adjunct to the medications for the motor symptoms is good treatment of mood, including depression and anxiety. All right, I'm going to turn now to trying to strategies we can use to minimize adverse effects of Parkinson's medicine. First of all, nausea can be mitigated by taking medication with food. And again, non-protein food if you have to take your medication with food, and it is necessary for many people. So bread or fruit can be useful strategies. Domperidone and other anti-nauseant medications can be taken if necessary. Lightheadedness on standing is a symptom that can be avoided with several different strategies: drinking plenty of water, taking extra salt. Compression stockings are quite tight stockings that can be put up to the well above the knee and can be bought at pharmaceutical supply stores, and they prevent the pooling of blood in the legs when one stands up. You can elevate the head of your bed at night to avoid early morning and middle of the night lightheadedness when getting up out of bed. Reducing, if necessary, reducing the dose of levodopa, dopamine agonists, and amantadine may be necessary. We can use domperidone or even extra carbidopa to help to reduce the side effects of levodopa that relate to effects outside the brain. And if necessary, we might need to use medications to raise the blood pressure. I wanted to introduce you to a study that was done and published last year in a prominent medical journal called The Lancet. This study was called the PD Med study and was carried out in the United Kingdom. And it was a study that shed some light on the effectiveness of different medication strategies for Parkinson's disease. They were comparing the long-term effectiveness of dopamine agonists compared with monoamine oxidase B inhibitors, compared with levodopa as three different initial treatment strategies for Parkinson's disease. And in this study that was done in a general practice setting in the UK, they enrolled over 1,600 patients with Parkinson's disease when they were first starting medication for the condition. And they followed them out over a maximum of 7 years. And they compared the strategy of starting with levodopa compared with the strategy of what they called sparing levodopa. And that was the other strategies of starting first with a dopamine agonist or MAOB inhibitor. And this was really to address the long-standing question of whether or not it's better to wait as long as you can before starting levodopa, or you might as well just start it up front, given that it's a very effective medication for Parkinson's disease. Many people try to spare levodopa initially and delay the starting of levodopa for fear that it will cause excessive dyskinesias later in the condition, or that people will get into cycles of wearing off and on-off fluctuations like you saw in the man in the video if you take levodopa too early. So what they found in the PD Med study, as you can see in these graphs, in graph A, you can see the mobility scores, where higher is worse, compared between the levodopa and the levodopa sparing arms. And you can see there's very little difference across the 7 years between the two strategies. And there was at 7 years, and indeed throughout the course, a slight advantage of levodopa over the levodopa sparing strategies. But this could hardly be considered a major effect because they're so similar. The bottom panel, panel B, is health-related quality of life scores, which is a scale which has some functional aspects to it as well. And again, you can see very little difference between the two strategies. In this last panel, what you see is the dyskinesia, the proportion of individuals in the study across the 7 years that are experiencing dyskinesias, and you can see that a higher proportion throughout the course in those in the levodopa initial arm were experiencing dyskinesias across the time, but at 7 years, once again, there's very little difference between the two arms. I think the overall message from this study is really that there's not a great deal of difference between different strategies, and that all of them are reasonable, and the strategy really needs to be tailored probably to the effectiveness of the medication at the time for the patient and the overall side effect profile, tailoring it to the individual. So I want to go back to talk a little bit about the management of dyskinesias. Dyskinesias come in two different types, and the first one I'll talk about are peak dose dyskinesias, which occur at the best effect, the time of best effect of levodopa or the dopamine agonist, and you can see that represented in the orange bars. And if we have dyskinesias at this time of best effect, then the answer to this problem is to reduce the peak action of the medication. We can do that by reducing the dose with each administration. We can use amantadine, which is a tablet which comes also in liquid form, which can be very useful to reduce the dyskinesias, or advanced therapies such as levodopa-carbidopa intestinal gel, i.e. duodopa, or deep brain stimulation can be very helpful for reducing this problem. Dyskinesias can also be diphasic. That is, they occur with either the wearing off of the medication or the start of effect of medication, so they have a very different timing pattern. Once again, the diary can be useful in figuring out which type is which. Here, the answer is very different. Here, we have to reduce the wearing off. And so you may be asked to take your medication more frequently to deal with this type of dyskinesia, lengthen the duration of action of levodopa, use an adjunctive medication for wearing off, such as an MAOB inhibitor or dopamine agonist, or once again, the advanced therapies can be very useful for addressing the diphasic dyskinesias as it is for the peak dose dyskinesias. But other than the advanced therapies, the treatment of this pattern of dyskinesias is very, very different than for peak dose. So it is really important to clarify for the doctor the timing of dyskinesias with respect to the taking of medication. All right. Moving on to other side effects that you may encounter, hallucinations and confusion are symptoms that we encounter later in the course of Parkinson's disease. And here it's very important to reduce medications because these are to some extent symptoms of the disease itself, but they are made quite a bit worse by the medication. We will often remove the most likely culprits, which would be the anticholinergics, amantadine, COMT inhibitors, or MAO inhibitors, and in some instances it may also be necessary to reduce levodopa, usually at the expense of the motor effects and functional mobility. I should have put a fifth one on that list of removals, which would be the dopamine agonist. If none of this works, or we cannot adjust medications without compromising mobility to a great extent, then we will often suggest adding medications that we call antipsychotic medications. And these would be quetiapine or clozapine, the most commonly used in this setting. Sleepiness can be addressed by reducing the dose of medication, particularly minimizing dopamine agonist use. And if that's not helpful or, again, can't be done without compromising function too much, we can use medications that promote wakefulness, like modafinil. Okay. The final adverse effect that I wanted to mention of the Parkinson's disease medications are the impulse control disorders. And these are problems that are characterized by compulsive urges to gamble, shop, eat, or engage in sexual behaviors. And there are other compulsions as well that can occur, but these four are the most common. And these behaviors are associated largely with dopamine agonists, but also can appear with levodopa. And they can be, as you can imagine, very disabling, very disruptive to one's life, and particularly problematic to detect and treat, because the patients themselves are often they don't freely share information about these behaviors, and sometimes it's not because they are not being truthful, but sometimes because they lack insight into them. And the core keys of management of impulse control disorders would be early detection, so having partner and family look out for concerning behaviors. So knowing about them is critical, and being on the lookout. If they're noticed, sharing that information with the physician. Secondly, preventing loss by preventing access to cash if necessary. And then finally, and most definitively, reducing or discontinuation of dopamine agonists is necessary in the presence of disruptive impulse control disorders. So I wanted to leave you with some what I consider key tips, and there could be many, but I've just chosen a few here. First of all, it's important not to delay treatment at the expense of quality of life. There is really no good evidence that delaying treatment results in a substantial benefit later on in terms of effectiveness of medications or reducing their side effects. Secondly, treatment of depression and anxiety are critical to good effects of medication and symptom control. Thirdly, timing of benefits and adverse effects in relation to dose are often key to optimizing benefit. And finally, Parkinson's disease is a slowly changing condition, and it does not change abruptly, at least in the brain. And if you notice your symptoms changing abruptly, or if you notice that suddenly adverse effects appear that weren't there before, or suddenly the medication isn't working, it's important not to attribute that to the progression of the disease, but looking for other causes. And the most common culprits here would be constipation, infection, particularly of the bladder or the lungs, or any other medical illness that might be interfering. And I believe that is my last slide, and I'm happy to take questions after this. Thank you very much.
Excellent. Thank you very much, Dr. Marras. That was a fantastic talk, and we've got a number of questions which have come in from more than 450 people who've been listening today. For those of you who are listening via the internet, I just want to remind you that if you want to ask a question, click in the text box and enter your question and click the send button. And as time permits, we'll answer your questions, and perhaps even if time doesn't permit, we'll be able to keep on doing that. So right now I want to open up our Q&A, and Dr. Marras, one of the things many of our listeners have pointed out and were really captivated by was your description about this patient diary. Is that something that can be available online that can download, or maybe if you have a copy you could provide to us and we could put it on our own website? Any insight?
I can certainly provide one for you. I have Googled it before, and I've found a number of patient diaries. So if I've Googled, diary Parkinson's disease, and you can get various versions of it online. But I'm happy to provide the one that we have for you by PDF, and then you can make it available to others. Sure.
Okay, great, thanks. I have a question from Texas for you. You brought up a lot of issues regarding the impact of medications and food interactions. But as you know, people with Parkinson's disease suffer issues with constipation and gastric dysfunction. Do any of these medications, fiber therapies, Metamucil or the Miralax, whatnot, affect the absorption or the timing of medications you would take?
That's a good question. So in general, I would. So the real answer is that it's not clear that the medications timing would be critical in relation to the medication. The fiber in particular may be the most likely to change the absorption of the medication, and it would make sense to avoid taking Metamucil, for example, right in conjunction with the levodopa. Other than that one, I don't believe any of the others would be a problem, so most of them can be taken easily without paying attention to the timing with respect to PD medication.
Excellent. So what are the pros and cons of some of these extended release medications? I know that there's a CR Sinemet in the United States. There's a new one called Rotari. What are your thoughts?
So I'm most familiar with the CR preparation and not so familiar with the Rotari preparation, of course, being from Canada. But the CR in particular can be problematic because it's not as predictably absorbed as the regular medication. So we tend to prefer, I think, the regular release medication unless somebody is running into problems of wearing off when the CR can be tried, and that's simply because the regular is more reliably absorbed.
Okay, thank you. So we've got a couple questions, one from New Mexico and Wisconsin, that are related, and it relates to advanced Parkinson's disease. As you know, there are many challenges late in stage disease, and particularly swallowing is an issue. But what are some of the other biggest ones regarding PD medications and late-stage disease? Is there other things that people should pay attention to as they work with their physician to help manage their disease? And maybe regarding swallowing, can you provide any specific advice on one way to alternative preparations or ways to deal with it? I think you mentioned liquid Sinemet as a possibility, but as you know, that probably makes it even harder to swallow.
Well, so liquid Sinemet actually can be useful because patients with Parkinson's disease can have in my experience, two different phases of swallowing difficulty. One is where the a rather universal symptom where people say, yeah, I have to take 2 or 3 swallows to get it to go down, and it often seems to stick halfway until I wash it down with water, and then finally it goes down. And for this type of swallowing difficulty, then crushing the tablet can be very useful. Now, crushing the tablet and, say, mixing it in applesauce or something like that that's more easily swallowed will avoid getting a tablet stuck in your throat or in your swallowing tube for any prolonged length of time. But what it also does is increase the rapidity of onset of action of the tablet, and a downside to that is that it often wears off faster too.
Interesting.
So that you have to sort of balance the pros and cons of that. The second issue with swallowing is more dangerous and happens later in the disease, where people have coughing with food or liquid, and there particularly thin liquids can be problematic. And managing that with some kind of thickener can be very useful for reducing the risk of aspiration. So their liquid Sinemet, yes, could be a problem, but can always be thickened just like any other liquid can be thickened with thickeners that you could buy at the pharmacy.
So, regards to the people with late-stage disease, I mean, swallowing is an issue. Are there particular side effect profiles to be concerned about with late-stage disease? I mean, we mentioned some of them regarding hallucination, but that seems to be maybe well modulated by adjusting some medications. What are some others might be concerned about? The hallucinations was one that really came to mind for me.
And then the swallowing difficulty would be nothing else is coming to mind right off the top of my head. If you have any specific ones that you're concerned about, then I'd be happy to address those individually. But I think really the hallucinations and confusion, as well as the managing the swallowing difficulty later in the disease, would be really the main medication-related issues, and I presume that's what you're speaking about. Dyskinesias is also something that evolves over time in Parkinson's disease, and so becomes an increasing problem with the changing disease. But again, we spoke about the strategies related to that.
How about one thing I was thinking about was regarding to anticholinergics and dementia. Confusion was brought up. You may be familiar with a study that was published in JAMA, and this is a question from a listener in California, that there's a correlation between high or strong anticholinergics and developing dementia. What are your thoughts on that? Has that changed how people are prescribing medications, your colleagues prescribing medications for dealing with Parkinson's disease?
Yeah, I don't think it's changed a great deal. I think it has done a good thing in increasing people's awareness of the relationship between cognition and anticholinergics, and it's very important. Anticholinergics would probably be the first thing that would be important to reduce if somebody is starting to experience cognitive decline in Parkinson's disease. And but it raises the bigger question about whether or not they should be avoided entirely. Anticholinergics are a class of medication, at least in my experience from my local physicians, that are not used routinely, and we use them in particular circumstances when there is intractable tremor that we can't otherwise get controlled. And I think they still have a very important role in that setting, because in those patients the tremor can be such a disabling factor that I think still their potential benefits outweigh the theoretical risk of causing permanent cognitive decline, which I still think is something that requires a sort of replication and further study on.
Absolutely. I certainly appreciate that. So another question, this one's from the UK. Can joint pain be a side effect of medication or pain in general?
As a side effect of medication? No, I think that it definitely is a symptom of the Parkinson's disease itself, but pain would not be something that I would be considering as a side effect of the medication per se.
Okay, good. DBS is one of the therapies you've mentioned for dealing with advanced Parkinson's disease. When one goes on DBS, how does that affect the medications you take? What differences might you see for someone who has DBS and Parkinson's versus someone who hasn't undergone DBS and Parkinson's? So let's say everything being equal, they're equal stages in their disease process. Right.
So usually patients with deep brain stimulation are taking dramatically reduced doses of medication, but they usually still do require some dopaminergic medication despite the action of the deep brain stimulation. So much reduced doses, but not gone completely. Dopamine agonists are often stopped in advance of deep brain stimulation treatment or implantation, and that is because of the fear of the effects of the dopamine agonists on mood and the possible manic effects that can be induced by the deep brain stimulation in conjunction with the dopamine agonists.
Would that be by manic effects? Are you referring to the impulse control disorders, or is it something else?
Well, both. So the sort of a hyperactive state, as well as impulse control disorders, both can be precipitated with the deep brain stimulation, and so dopamine agonists are often stopped in advance of deep brain stimulation. And so that would be sort of the specific medication profile that might be different, but in general, medication doses are all quite a bit reduced.
And I guess as reducing those medication dosages, you also minimize the side effects they might produce as well.
That's correct.
Okay, that's good. I have a question from New England regarding whether any of the drugs that people might take for Parkinson's disease cause a dry mouth or cotton mouth, or is that something that people with aging experience overall to begin with? And I could imagine as one ages, there's other diseases you're battling and might be taking medications that might do that. But regarding Parkinson's, are there any PD meds which might give you the cotton mouth?
So yes, indeed. So anticholinergics would be the biggest culprit for that, but also amantadine and would be the second biggest culprit. And then I've had many patients complain with all the medications of Parkinson's disease causing dry mouth, but I'm not sure that any others have been proven associations.
Interesting. We talk about some of these other side effects. People are often taking multiple medications for their Parkinson's disease, and this is a question from Canada. Does it matter whether you take your Requip and Cinemet together? Do they need to be separated? Or regarding your PD meds in general, how does one take those?
So they're often used together, and it's not, none of them are problematic taken at the same time as the other. And whether or not it's recommended to take them at the same time or apart really depends on the duration of action of the medications and how we're trying to use timing in order to smooth out the overall effects across the day of the medications. So it's not problematic to take them together, but you may be advised to take them staggered in order to provide better and smoother coverage of the day.
Another question from Canada, Toronto, actually. And you mentioned some of the side effects of the medications that people take involve sleepiness. Yet, sleep remains a real challenge for people with Parkinson's disease. Is this a result of the medications that people are taking, or the disease progression? Are there medications that people can talk to their physician about in order to help alleviate some of their sleep problems? What are your thoughts?
Right. So sleep and medication is a bit complicated. The one medication that I would caution people about with respect to sleep would be selegiline, which itself can interfere with sleep, so shouldn't be taken after about noon in the day. The other medications have really variable effects on sleep, sometimes sleep-promoting and sometimes activating, and so they may inhibit sleep. And it's to some extent patient-dependent. So it really depends on some experimentation as to whether or not the medication close to bedtime aids or interferes with sleep. For example, levodopa can have good effect on relaxing the muscles and making people much more comfortable, and has itself sometimes the side effect of sleepiness from the medication can all be sleep-promoting. On the other hand, some people feel activated after they take their medication and have a sort of a euphoric effect from the levodopa that actually makes it more difficult for them to sleep. The dopamine agonists would be an example where this activating effect can be particularly noticeable, and they may need to pull the agonist away from the bedtime. So it really is individually dependent and requires some experimentation on the patient's part.
Really need to work with your physician about some of these issues. I have a question from Ohio for you, and regarding, again, efficacy of medications and absorption, but maybe in general, working together to really maximize your quality of life. What are your thoughts about exercise, particularly intense exercise?
So in general, I think exercise is beneficial and very important for maintaining physical function. There's evidence for the benefits of resistance training as well as endurance training, and even lighter exercise like stretching. Now, intense exercise can be, I think, a very good thing, and I would not discourage it unless it's done to the extent where somebody is wearing themselves down. As many of you know, there is a lower energy level in Parkinson's disease, and fatigue is a significant problem. So you have to know your own limits in terms of what you can tolerate without getting progressively more fatigued. And so avoiding fatigue, then any exercise that you can tolerate is generally beneficial.
Okay. Again, thinking of things that you can do as an adjuvant to help your medications. Some questions, many questions have come in regarding the issue about vitamin D. As you know, there's been lots of reports about vitamin D being low in people with Parkinson's disease. Is it important for people with PD to be monitoring their vitamin D levels? Does it alter their symptoms? Does it alter the course of their disease? What do you know about this?
So the short answer is we're not sure, but vitamin D, at least in cross-sectional studies, has been associated with better cognitive function as well as reduced falls in people with Parkinson's disease. And so we on that basis, we generally recommend taking at least 1,000 units of vitamin D daily. But nobody has done a randomized clinical trial that follows patients with and without vitamin D over time to really see what the cause and effect relationship is between vitamin D and Parkinson's progression. Okay.
Here's another issue. I don't recall exactly if you addressed this in your talk, but one symptom that's really problematic with people with Parkinson's disease, and this comes from a listener in Pennsylvania, regards that of balance problems and falls. Is there any medications or any treatments available to really ameliorate this issue? What is there to help people who are managing and struggling with this daily?
So medications are generally very poor at improving balance. Earlier in Parkinson's disease, and even in the mid stages of the disease, the medications can improve balance by helping the movements become quicker. And so that if you're pushed off balance, for example, you're more likely to be able to catch yourself because your foot will move faster under your center of gravity and to catch yourself. But as the disease advances and what we call postural stability really becomes much more impaired, the medications are very poor at improving that. And we advocate exercise to improve balance, maintaining a walking routine, as well as exercises like Tai Chi, which sort of just makes sense on face value to keep your balance in practice. But medications have a very small role in improving balance later in the condition.
Well, it really remains an unmet need, and I think it's something that research hopefully will elucidate a way to solve. Dr. Marras, Connie, I would like to thank you very much for your time today and your wonderful presentation and answering the many great questions we had from our listeners, 18 countries. We had over 450 people who were live today and almost 1,000 who registered overall. So I think you're going to really impact the lives of many people in our community. I also want to remind people that as we finish the talk, that you should complete our online survey that you'll see on the screen. Your feedback is critically important for us to help improve our webinars. And we actually listen to our community, and I think that's something that the Parkinson's Disease Foundation does incredibly well, and to listen to what the people who live with the disease and what their questions are as we try to formulate many of our programs. And expert briefings certainly is one of those. And also, this is expert briefing series is not a free production for us, and we're really dependent and grateful to both of our sponsors, AbbVie and Acadia Pharmaceuticals, who have both made this series possible for everyone, as well as many of our partners throughout the country who've collaborated with us in order to get this to work. So I want to let you know that if there are any questions you might have about this series, want to go back and listen to it again, we'll have an archive of the event, and it'll be made available starting next week Tuesday, May 5th. Mark your calendars. Visit pdf.org, our website, and we'll send you an email with a link when it's available so you can listen to it again, or you can let your friends know about it.